right, well, good morning, everyone. Welcome to this morning's Kangos lecture. This is our annual lecture we do. Jim Kangos received his undergraduate education at Bucknell University and his medical education at Rutgers Medical School and Tufts University School of Medicine. He was a resident in pediatrics from 1977 to 1980 and outpatient chief resident from 1980 to 1981 at the UPMC Children's Hospital of Pittsburgh, an institution for which he maintained deep affection. Therefore, he was engaged in the private practice of pediatrics, thereafter, he engaged in the private practice of pediatrics in Connecticut until 1986, when tragically he died before his 35th birthday due to complications of ulcerative colitis. During his brief career, he championed the cause of foster children and worked effectively to reform regulations governing his disadvantaged group for whom he had special affinity. He was born into a close and nurturing family, and with his wife, Vicky, perpetuated a tradition of family values that they instilled in their children, Edward, Allison, and Michelle. Jim wore a constant and warm smile and laughed with unstudied and unstinted joy. He bore frequent pain privately with quiet grace, faced uncertainty with optimism, an optimistic confidence, and confronted his too early terminal struggle with uncommon courage and characteristic concern for others. It was Jim's wish that his annual lectureship be established at the Children's Hospital of Pittsburgh of UPMC to stimulate future physicians to study and ultimately control inflammatory bowel disease, so that some good might come from his ordeal. He left money for this purpose, which with funds donated by his family and friends will perpetually support this worthy goal and honor the memory of a deeply missed colleague and cherished friend. And so today I'm extremely excited to introduce to you Dr. Hilary Michel. She is an attending of pediatric gastroenterology at Nationwide Children's Hospital, and she's the director of the medical home and transition program within the Center for Pediatric and Adolescent Inflammatory Bowel Disease. She's an assistant professor of clinical pediatrics at The Ohio State University, and Dr. Michel attended Case Western Reserve University for her undergraduate education and completed medical school, general pediatric residency, and pediatric gastroenterology fellowship right here at Children's Hospital. Her clinical interests include general pediatric gastroenterology with a focus specifically on children and adolescents living with inflammatory bowel disease. Her research interests center around providing comprehensive care to children with IBD and their families, focusing on multidisciplinary care delivery and healthcare transitions. She also has a passion for medical education, directing the GI Fellow IBD curriculum at her institution, mentoring medical students, residents, and fellows, and a variety of quality improvement and research projects. We very dearly love her and hold her close to our hearts, and we're really excited to see her lecture today.
Thank you so much, Whitney. Thank you to the GI Division. Thank you to the organizers of the Grand Rounds here at UPMC Children's. It is such a treat to be back, to see such wonderful familiar faces from the past and the present. And I'm thrilled to be able to talk with you all about topics that I'm passionate about that Whitney mentioned: multidisciplinary care, transition of care, and how do we really optimize the care we provide to our patients with chronic diseases. So I do not have any financial disclosures to share with everyone, although I do have some disclosures that I am an incredible Yinzer. And as Whitney said, proud Pitt Med grad. Here's the fabulous Dr. March and I on call. She's one of our endocrinology attendings, as I'm sure you know, in 2016, nights as a resident. And then this was my last day of fellowship. I took a picture of that pager that probably at one point I wanted to throw down some stairs in my badge. So it is such a thrill to be back. Pittsburgh shaped me as a physician, as a person. And I probably should put on here that I married a Pittsburgher and have a dog named Jerome Pettis. So it runs deep. So during our time together today, we will be talking about a variety of things. First, I hope to establish with everyone why young adults and children with inflammatory bowel disease benefit from multidisciplinary care and really need it. Second, to use transition and transfer to adult care as a case study for why this multidisciplinary care is so important. And then finally, to share one model of how we might deliver this multidisciplinary care from diagnosis all the way until we ship folks off to the adult setting. And I'm hopeful that these concepts will also be applicable even to our non-gastroenterologists in the room, anyone who takes care of kids and young adults with chronic disease. So for those of us who are not pediatric gastroenterologists, a quick refresher on what IBD is, or inflammatory bowel disease. It is a chronic inflammatory condition of the GI tract caused by a dysregulated mucosal immune response to intestinal microflora in a genetically susceptible host, the kind of perfect storm that comes together. There are over 3 million folks in the United States that have inflammatory bowel disease at this time, about a quarter of whom are diagnosed in the pediatric setting. We know that pediatric IBD is more likely to be severe and extensive in comparison to adult onset disease. And while there is no cure for inflammatory bowel disease, we happily have a growing armamentarium of medical, dietary, and surgical interventions that help our patients live healthy, long lives. So moving on to what are the goals of therapy in IBD, the first piece is obvious. We want people to feel good, right? We want those classic symptoms of abdominal pain, diarrhea, blood to improve, and for kids to feel great. Then we want to follow blood tests and stool tests for normalization, for improvement in that inflammation. Then we want to look inside and check for healing of the mucosa. That's one of the newer goals. Mucosal healing are things really better on the inside. But I really want to emphasize in today's talk that last blue circle on the right, which is we want people to have a normalized quality of life and absence of disability. So it's more than just cleaning up the blood and making sure stools are formed, although we're very passionate about that too. We want people to feel good and live their life and be kids or adolescents. And so that leads me to the fact that IBD and its therapies affect not just the person and symptoms, but the whole sphere in which they live, their families, their peer relationships, and so much more. And that is why young adults and children with IBD require a multidisciplinary team, which I will make that point to you in the coming slides. So to get us all in that mindset, I want to have us all focus on a patient who we may see in clinic. Alexa, 13-year-old young lady, she was just diagnosed with ulcerative colitis. She showed up classically with belly pain and bloody diarrhea. We were starting her on oral prednisone and mesalamine for her therapies, both pills by mouth, but then soon learned that she can't swallow pills. So that's been really challenging to navigate. She also presented with pubertal delay and joint pains. She lives with her dad and her younger brother who has autism. And from a psychosocial standpoint, she's in 8th grade. Like many of our patients, she's super active and engaged in her extracurriculars. And when you ask her how things are going in terms of talking to her peers about this new diagnosis, she says it's been super tough. She's not really been able to talk about it at all. So with Alexa in mind, I want to talk about how IBD is affecting the whole her. First of all, I mentioned that she had joint pains. So extraintestinal manifestations in IBD are common and can truly affect the whole person from head to toe. And I love this figure because it highlights the importance first of the primary care provider, who may be the first person to see many of these presentations either before IBD diagnosis or after. And then also the importance of all of our incredible colleagues, our dermatology colleagues, pulmonology, rheumatology. We truly need the village to take care of young adults and children with IBD. And it goes beyond the gut is the take home for this slide. I also mentioned that Alexa had pubertal delay at presentation, and that's linked to this next topic, which is growth and nutrition. So malnutrition is present in up to 85% of children and adolescents who present with IBD. It's very, very common, and there are many causes as to why our patients show up with malnutrition. Malnutrition is also commonly associated with growth failure. You can see both of those on the slide to the right. And growth failure is connected bidirectionally actually with pubertal delay. It's contributed to by the inflammation that's happening in the gut. And it's also contributed to by the medications we use, like corticosteroids. When people think about malnutrition, the next thing they think about is diet. If kids are malnourished, how are we managing that with nutrition? I love this slide for multiple reasons, but what you're seeing here is along the x-axis a variety of different diets that are used to treat either the symptoms or the inflammation of IBD, and then along the y-axis a variety of drinks and foods. And the colors indicate whether these foods are mandatory, allowed, not mentioned, limited, or not allowed. And I want everyone to look at this and search for a pattern, and then realize there is no pattern. It's completely overwhelming. And this, in addition to the significance of the malnutrition in our patients, makes me say that dietitian involvement is essential for management of our patients with IBD. First, our dietitians can help us assess patients, assess their nutritional status, and help diagnose and avoid nutritional deficiencies. And then second, they can help us navigate this super complex landscape of dietary therapies for IBD. One, are we using a diet to treat inflammation? Versus two, are we using it to treat the symptoms? Because they're not always the same. Versus, well, not versus. In addition, three, we need to find a balance. No matter what diet we're recommending for patients or they're interested in, we need to make sure that it's meeting all of their nutritional needs, especially during childhood and adolescence as they grow and develop. So shifting gears a bit, how about mental health in young adults with IBD and children with IBD? Are the kids all right? Well, unfortunately, just like our young adults who don't have inflammatory bowel disease and children who don't have inflammatory bowel disease, our kids with IBD also are at increased risk for anxiety and depression and suicide. Depression rates are up to 25% in children with IBD, and anxiety and depression, in addition to being problems on their own, are associated with poor healthcare outcomes in our patients: treatment non-adherence, recurrent disease, active disease, poor quality of life, and increased healthcare utilization. I'll highlight here just a few studies that underline what I just mentioned. This is a report from over 3,000 Danish children, and they looked at these children over time, and these are survival curves looking at how long patients went without a diagnosis of depression, anxiety, or an antidepressant prescription. The blue dotted line is the control, and the red is the IBD group. And you can see that over time, those lines very clearly separate, with increased risk of both depression and antidepressant use in this population compared to the healthy control population. This is another very large population-based study from the UK, looking at, again, over 3,000 pediatric patients and young adult patients with IBD. And what you can see here at the bottom of the left graph, that there was a significantly increased risk of having any mental health condition amongst the IBD cohort. And then I thought it was interesting that they broke it down by different types. So increased risk of post-traumatic stress disorder, eating disorders, self-harm behaviors, sleep issues, and anxiety and depression in comparison to the healthy controls. This was a unique take. The researchers here in the United States looked at over 160,000 hospitalizations for IBD, and then looked at those IBD hospitalizations for how often a concurrent psychiatric or behavioral health diagnosis was listed as part of that hospitalization as well. And what they found was, first, over time, the prevalence with which there was a concurrent psychiatric diagnosis during that IBD hospitalization increased from about 12% in 2002 to nearly 20% in 2018. And then their next graph, they looked at over time, what was the cumulative prevalence of a psychiatric disorder amongst the patients admitted to the hospital. So at 3 years of age, about 4% of those admitted patients had a concurrent psychiatric diagnosis during their hospitalization. And by the time they were 20, up to 25% had a concurrent psychiatric diagnosis. And the types of diagnoses during those hospitalizations varied a lot. Anxiety and depression are predictably there in orange and gray respectively, but I was really also impressed by the substance use, 22% of patients. So this is really common, really challenging stuff. Post-traumatic stress is one of the newer areas of mental health that is being examined in IBD. Up to 25% of patients with IBD will report symptoms of post-traumatic stress. And once again, these symptoms are associated with adverse health outcomes for our patients. Also, unsurprisingly and disappointingly, the folks that are more at risk for post-traumatic stress symptoms are the folks that are already at risk for poor health outcomes, such as women compared to men, Hispanic compared to non-Hispanic folks, non-white patients, as well as those with lower educational attainment. Our already at risk patients are suffering more. Body image satisfaction or dissatisfaction is another area that's being studied a lot within IBD, and actually many GI conditions that are associated with food. About 11% of teens with IBD reported body image dissatisfaction in this survey study of about 600 young folks. And you can see that as the BMI quartiles increase, the dissatisfaction in one's body increases as well, up to close to 20% in the patients in the fourth quartile to the right of that graph. Female patients, patients who are older, patients with active disease, those with steroids, and those with underlying mood disorders are at increased risk. And I feel a little bit like a broken record, but once again, patients with with body image dissatisfaction are at higher risk for disordered eating and poorer self-care. So these findings have ripple effects that really affect our patients and their lives. And so hopefully I've made the case here that psychology involvement is essential for these patients. First, to screen for all of these conditions that we know our patients are at higher risk for, because I know despite our best efforts, it's really hard and maybe impossible to screen for all of this in a routine clinic visit. And then second, because there are treatments that work. So this is a systematic review of cognitive behavioral therapy in people with IBD. And what they found is that it significantly improves anxiety, depression, IBD-related quality of life, and somewhat not surprisingly, the longer you're receiving CBT, the better you do. Also very cool was that this study demonstrated efficacy no matter how the CBT was delivered, whether it was in person with a therapist, online, or through a self-directed CBT app. Patients did better when they received this therapy. Here's another study of gut-directed hypnotherapy delivered again by a psychosocial provider that showed significant improvements in the intervention group in terms of days to relapse. Patients went longer without IBD relapse in the intervention group, and they also had higher proportions of remission in the intervention group compared to the attention control. And then this study was specifically in pediatrics. They looked at the effects of psychotherapy on healthcare utilization and saw significant decreases across the board: hospitalizations, ER visits, scopes, labs. So this stuff really works. We need the professionals to do it. And this study I thought was really interesting. They looked at the rates of post-traumatic stress symptoms in adults with IBD, and then they also looked at modifiable traits that would improve the experience with hospitalization. And this is stuff we can all do. So patients had better hospitalization experiences when they reported that nurses treated them with respect, that physicians listened, that the room was quiet, and that their anxiety and pain were well controlled. So these are things we can do in the hospital to help patients have better experiences and hopefully less trauma associated with their hospital experiences. Moving beyond the individual person, I want to go out into their regular life and talk about school and peer relationships amongst children with IBD. What we know here is that there is an increased risk for missing school due to appointments and symptoms of IBD, which makes sense. And certainly the more sick someone is, the more likely they are to miss school. The data are actually mixed in terms of academic performance in patients with IBD. Some say that they struggle compared to healthy peers. Some say they do just as well or better. But what we do know is that there's lower social functioning compared to youth without chronic illness. And patients who are diagnosed as adolescents are at greater risk for this than those diagnosed as children. IBD affects the whole family. And I'm sure we have all seen this again, whether you take care of kids with IBD or other chronic diseases, but the parents of kids and caregivers of kids with IBD experience enormous feelings of guilt, worry, stress, anger, shame. And one, that makes us sad because we want parents and caregivers to be happy. But two, and I'm sorry, I meant to mention this too, the levels are quite high. 50 to 60% of surveyed parents shared that they experience high levels of distress, not just a little bit of distress. And these symptoms and feelings in parents and caregivers not only make them feel terrible, but trickle down to the well-being of the patient. And so I love the figure on the right there, because you can see that having a flare of disease or active IBD negatively impacts child health-related quality of life. It increases parental distress predictably, but then there is a additive, separate negative impact on child health-related quality of life if the parent has significant distress. And then finally, thinking even more broadly about costs. So IBD is enormously expensive, and costs have been rising over time. This graph starts in 2008 and looks at unadjusted all-cause costs for IBD. The dotted line at the bottom are healthy controls, and then the line up above is the cost for those with IBD. And mainly the thing here is you see significantly higher costs amongst the patients with IBD, and then there's this sharp incline in between 2012 and 2014, likely related to many of the medicines we use, which are called biologic therapies. We know that patients with IBD have 2 to 3-fold higher costs in general than healthy folks. They also have costs when it comes to missing school and work, which we sometimes don't think about in pediatrics perhaps as much as we should. Their parents also have costs in that setting. And the drivers, as I mentioned, are meds, our ED utilization. We talked a little bit more about the things that can decrease healthcare utilization amongst our patients. And then healthcare services for active disease, anemia, and mental health. And so all of those things were shared because I also feel that social work involvement is essential for our patients. Social workers can do a million things, but many of them, or some of the ones that I think are most helpful, are listed here on the side. They can help our patients navigate the incredibly complex and confusing insurance landscape. I find it, every time I have to do my, what's it called? That selection, it gives me deep anxiety. And I know, and we've been in school for 12,000 years, right? So I think about our patients and families who are navigating this landscape. Social workers can help them do that. They can also screen for and address social determinants of health that are impacting our patients. They can provide family and sibling support, and they can help our patients develop school and work accommodations to allow them to thrive. I liked this graph because it just listed off several of the work accommodations that folks could request, but many of our patients and families don't know what to ask for until they are told. And there's so many legal protections both in school and in the workplace to help our patients thrive. So from the first chunk of this talk, I hope that I have convinced everyone that IBD is complicated and can impact truly every part of a patient's life, and that also a multidisciplinary team really is needed to identify and manage all of these challenges. And so now we'll shift gears a bit to talking about transition and transfer of care and show that this is also a process that really deserves a multidisciplinary team to do well. Back to Alexa. So we've fast forwarded 5 years. She's now 18. Unfortunately, she didn't respond to her mesalamine oral pills, though she did learn to swallow pills working with our psychologists. And now she is on infliximab infusions every 4 weeks and doing great. She's hearing back from colleges. She's gotten into a bunch because she's super high achieving and she's trying to make decisions on where to go. She shares that she is struggling with some anxiety, also with some body image concerns. And unfortunately, her dad lost his job recently. With that, lost his insurance. And so he's feeling completely overwhelmed with her next steps and with his other child who has some special healthcare needs. And so thinking of Alexa and thinking of as she navigates this transition of care, we'll do a few definitions. So transition of care is a journey. It's not a one step in time. The official definition, is the purposeful planned movement of adolescents and young adults with chronic conditions to adult-oriented healthcare systems from usually a pediatric healthcare system. And then the transfer is that point in time when they actually make the leap from pediatrics to adulthood. This schematic shows that transition process. So we have time along the bottom. Over time, patients gradually have increases in their disease-relevant knowledge and skill set, self-management skills. And then I think this is a European paper, and they use this term parental grip, which I find to be hilarious and, and kind of colorful. And you see this slow decrease in parental grip over time as well. And then you see that dotted vertical line for transfer to adult care. And I really want to highlight here that all of those triangles extend beyond the transfer. So even though our patients are no longer in our care when they get to the adult setting, growth in knowledge and skills and slow tapering of parental or caregiver involvement really should continue after they get to the adult setting. Oops, did I skip one? No. So ideally, transition and transfer provides care that's age appropriate, that is planned and coordinated, no surprises, and that's uninterrupted. There's not a big gap between the pediatric and the adult care delivery. Also, ideally, transition and ultimate transfer of care occurs when a patient is ready, when they have those knowledge and skills, and when their disease is well controlled. That's what we know predicts most success. But the reality is that the post-transfer period is a really high-risk period for young adults. Young adults are at increased risk for poor adherence, increased disease activity, lapses in routine care with increases in unplanned care like ER and urgent care, and significantly increased rates of poor satisfaction with their care and decreased quality of life. This study, which was completed in Canada, looks at healthcare utilization, both before transition, then they had a washout period, and then after transfer to the adult setting. And what they found was that there were significant increases in outpatient healthcare utilization, 2 times increase in ER visits after transfer to adult care, and increased laboratory ordering and completion as well. So that begs the question, is the transition from adolescence to adulthood really seamless? This cartoon resonated with me as someone without IBD, and I'm sure would resonate with many of our young folks with IBD. Is this really so great now that I have all the responsibility? And I think part of this is set in the fact that young adulthood is a really unique time. We've all been there, right? There are highs, there are lows, but there's a lot of change. Developmentally, young adults are still developing their frontal lobes and so on. There are huge shifts in roles, right? In the past, perhaps there is this triad of caregiver, patient, provider in the office that may be shifting to more of a dual interaction between the patient and the provider, him or herself. Increased independence and autonomy as folks start new jobs, go away to school, new responsibilities, social pressures, everything else in life is shifting. And at the same time, we're asking young adults to take over their medical care and be adults and be in charge. We know that across the states, and in fact across the world, but the study is in the United States, transition care delivered to young adults with IBD is incredibly variable. So this study surveyed over 140 providers from 90 different US institutions and asked them, what things are you doing for your young adults with IBD to help them transition and transfer to adult care? And the point here is really to highlight the variability. Some things, for example, like providing a list of adult providers to patients, was reported to be happening about 3/4 of the time. Okay, that's pretty consistent. Other things like spending time one-on-one with your patient, with the parent or caregiver out of the room, was only reported to be happening about 50% of the time. And then still other things like providing a healthcare summary that the patient can take to the adult doctor was happening only about 1/3 of the time. So massive variability in the care that we're providing. And then this was a survey study that actually was part of my fellowship project, where we asked adolescents with IBD and their parents in the last year, who has talked to you about these different topics? And what you can see here is over 75% of both adolescents and caregivers in a center as incredible as this one said that no one had talked to them about transfer of care or transition of care in the last year. And that included not only their GI docs, but their primary care providers and other team members involved in their care. So it's variable, we're not talking about it. The question is why, and it's because it's really hard. And there are lots of barriers, to successful transition and transfer. And those can be lumped into a few different categories. Sometimes we lump them by which player the barrier is most related to. And sometimes we lump them into themes like relationships, skills, efficacy, and access insurance. So we'll talk through a few of these here. All right, so first from the patient level, I always like to start with relationships because this is why most of us are pediatricians. Connections to the pediatric team can often be a barrier to successful transition and transfer. We take care of patients from the time they're diagnosed all through ups and downs in their life, and that makes it really hard to let go and say goodbye and move to an adult setting with all new folks. Similarly, our patients share that they have specific beliefs and expectations about the adult setting, which are often not super positive. They worry about the care they're going to receive. They worry about the providers not being as nice as us. They have a lot of concerns, and that makes it hard to let go too. From patient to patient, there can also be barriers related to skill and self-efficacy, and we see this all the time. Some patients are managing their own care from the time they're 9 years old. Some patients, they're 26 and you're still wondering, Do we know what disease we have? And so that really can act as a barrier as well. Knowledge, linking similarly to the skills and self-efficacy piece. And then health-related factors. And I think this is really important. So in a patient who has very active, severe disease or complex disease who needs a surgeon and a hepatologist and an infectious disease doc and a rheumatologist, it's really challenging to smoothly transfer that patient to the adult setting. If there are comorbid mental health disorders, we also know that that makes transition and transfer harder. So then we're not going to blame it all on the patients, right? So we play a role in this as well when we are getting our patients ready for transition and transfer. What do we bring to the table or perhaps make more challenging for our patients? Start with relationships again. We love our patients. It's really hard to let go. And I can speak for myself that there are several patients that maybe I held on to, oh, let's just do one more visit. You know, you just don't want to say goodbye to them. They've been part of your life, and that's really special. We as pediatricians also have beliefs and expectations about the adult system that may not be as positive as they should be. We also tend to have a lot of faith in our patients and overestimate their transition readiness, their knowledge and their skill, and then they get to the adult world and may have some challenges. Pediatricians also report a lack of knowledge and skills around transition preparation. So if you haven't spent some time reading or thinking about transition readiness, your ability to guide your patients through those stages to help them gain knowledge and skill might not be as strong as you wish. And so that is a hesitation amongst pediatric providers. And then finally, there's a lot of systemic and logistic bits that we probably have all run into as well. Is there an available adult provider with the expertise you want to see your patient? Are you able to connect with that adult provider and coordinate smoothly with them and communicate with them? And then, of course, resources and time. We'll talk a little bit more about what a transition program can look like, but it takes people and money and time and space to deliver a transition program, and that is sometimes hard to come by. From the caregiver perspective, broken record here, once again, relationships, right? We connect with parents and caregivers deeply. We're with them in really difficult times, and it's hard for them to let go to the pediatric team, but also very importantly, hard for them to let go of their young adult child. A lot is changing for them too, and that is a scary, scary thing and an important thing for us to acknowledge. Beliefs and expectations, once again, some parents and caregivers are hesitant to relinquish that responsibility. It's scary to let go and let the young person fly. And then research studies have shown that some parents overestimate their young adults' readiness and knowledge, and then other parents overestimate and underestimate, depending on the study. Knowledge, similarly, many parents don't know what to expect when it comes to transition and transfer. When does it happen? Do you get booted when you're 18? And so on. And so that's part of our job there, to talk about transition and transfer from the jump, so that it's not a scary thing that's going to pop up and take their kid away to the adult setting at 18, but rather it's a process and we're here to support them through it. And then skills, again, letting go is a skill, delegating is a skill, and different parents and caregivers are going to have different abilities to do that. From the adult provider standpoint, they have also reported a variety of barriers when it comes to receiving our patients. They often are worried about the knowledge and skills that our patients have. Are they ready? Do they have what they need to fly in the adult setting? They worry that we enable our patients, which probably we do, again, speaking personally. They worry about the excessively involved parent or caregiver in the office, and about how they're going to manage those expectations during the transfer or after the transfer. They also share that they worry about being able to adequately manage pediatric onset chronic disease, because it's not the same as adult onset chronic diseases. And they worry about their ability to continue to deliver transfer care, or transition care, I should say, building knowledge and skill afterwards. And then once again, logistics and systemic barriers. Very, very frequently, the biggest complaint from our adult colleagues is that they don't receive thorough records, or they receive a pile of Xerox stuff 5 inches thick, which are mostly, just illegible. And so they worry about that. They worry about communication with us, and they also worry about lack of access to a multidisciplinary team. If our patients are used to receiving multidisciplinary care in the ped setting, they transfer to the adult world and then are left with a sole GI doc taking it all over. It can be very, very difficult. And then finally, I would be remiss not to mention the systemic and logistical barriers that are applicable across the board for our patients, and especially our patients with chronic diseases. So social determinants of health, including education, access to healthcare, safety and healthiness of the neighborhood, social safety and a safe community, and then of course finances can really get in the way of our patients accessing the care they deserve and they need. And then I already mentioned this a little bit more in the social work side, section, but insurance and cost of care is huge. How to obtain and navigate insurance, how to find a provider that takes your insurance, how to manage out-of-pocket costs, all of this stuff is really, really challenging for our patients as they transfer to the adult setting. Now, that's all kind of doom and gloomy, but the good news is that studies have shown that transition interventions can improve outcomes for our young adults as they get ready to and then transfer to the adult setting. It's really difficult to summarize the intervention data on transition because the interventions are different in every study, the populations are different in every study, and the outcomes measured are different in every study. So there's not a great way to summarize them, but I'll try my best here. So the most common interventions that are used to help improve transition care include dedicated transition clinics. So sometimes there are young adult dedicated clinics where you come in and you focus on young adult topics and transition topics. Some centers have joint pediatric and adult visits where you have both docs in the room at the same time, or healthcare providers in the room at the same time. With the acceptance and welcoming of telemedicine, some centers have found that to be a bit easier to get both docs in the room, if you will, at the same time. Other interventions focus more on either individual or group coaching in terms of gaining those skills and knowledge. And then other studies look at care coordinators, transition coordinators to help smooth the process as well. And these studies, as I mentioned, study multiple different types of outcomes. Some of them are related to disease activity and complications. Many of the studies measure things like transition readiness, and there are a variety of different tools to measure that. Measurements of self-efficacy, knowledge, quality of life, satisfaction with care, and then healthcare utilization and costs. So we are not spinning our wheels. I think our interventions can work, but there's still a huge question of which interventions work best for which outcomes. Lots of, if anyone is looking for research projects, there's much to be done here. Here are just a few examples of transition-related interventions that helped. So this was a study done in the UK, and they randomized patients either to non-transition intervention, which is kind of baseline care, versus a transition intervention, which involved at least 2 combo visits with the adult and the pediatric GI doc in the same room. And what they saw was a significant difference in the number of flares in the intervention group, a significant decrease compared to the control group. And they saw a significantly higher steroid-free remission rate in the intervention group compared to the control group, which is something that we think about a lot in IBD management. This study was done in the United States. It was a multi-center study that looked at a pre-post intervention. The intervention itself was a group educational session, first in person, followed by 4 individual telemedicine visits with a transition coordinator where they worked on skills and knowledge and goal setting. And what they found here was, once again, significant improvements in all of the outcomes they measured in the pre versus post periods. Those included a measure of transition readiness, number of skills mastered, both parent and adolescent/young adult readiness to transfer, and then also IBD-related knowledge. And I believe this study also was a pivot during COVID, and the individual telehealth-based interventions were not the plan and became the plan and still worked, which is kind of cool. This is another study that just looked at a one-time encounter with a transition coordinator versus routine care. And during that one-time encounter with the transition coordinator, patients with IBD focused on education, again, goal setting, skill building, problem-based scenarios of what would you do if you lost your insurance, et cetera, et cetera. And what they found here was a significant improvement in the TRACK score, which is a validated transition readiness score, and significant improvement in the number of self-management skills mastered amongst the intervention group compared to the controls. And this slide is just to show that bigger, multi-center, randomized trials looking at interventions to help transition and transfer are being planned and are happening. I think that everyone is interested in improving the rigor with which transition research is being done. And so one of these studies is in Canada. I think the other one is in Denmark. So more to come. So take homes from part 2 would be that transition and transfer are inevitable and are a good thing, right? We're getting better at managing chronic diseases, and the fact that our patients are becoming adults with chronic disease is a good thing. But it's a high-risk time. There are lots of barriers, and there's lots of research to be done to figure out what actually works the best. And so last but not least, we'll talk about one model of how care from diagnosis through transfer of care could be delivered. And to get there, I will start with this sentence. So when I was a fellow, one of my mentors, Sandy Kim, asked me, what is your goal? What if you were to change the world of IBD, what would you do? And I workshopped this and so on and so forth, and eventually came to that I would love to build a comprehensive care model for pediatric IBD informed by patients and families. And as I dug into, well, what would that look like? I stumbled upon the concept that was certainly not created by me and created decades ago of the patient-centered medical home. And so this may be something that we've all read about or learned about, especially in primary care pediatrics, where you have the patient at the center and the care that is delivered to that patient is comprehensive and coordinated and of high quality and accessible. And it's because it's nestled within this network of a multidisciplinary team. And then I kept digging and I said, oh my goodness, the adult IBD doctors at UPMC created an adult IBD medical home already. So this figure looks very similar to the last one. Once again, you see the patient in the center, surrounded by their neighborhood of multidisciplinary team members, dietitians, psychologists, social workers, surgeons are out there too, pain specialists, peer mentors. And I thought this is really cool that patients with IBD could be managed in a medical home setting and receive everything that they needed, ideally in one place. So why does a subspecialty medical home make sense for patients with IBD? This applies to both the adult and the pediatric setting. Well, first, we've established IBD is really complicated. The care is complicated, it's expensive, and it's really prone to fragmentation with all of those different providers and specialists. We also know and have discussed that costs are rising for IBD care, and in most settings, the cost of managing a disease is driven by a minority of patients. And so this is actually the adult UPMC data from several years ago, but you can see that 14% of patients were driving 46% of costs within their IBD medical home. And we know that patient-centered, team-based coordinated care may help address some of these issues, which increases the value of the care being delivered. So there's this concept of value-based care, where if you're able to increase the health of the overall population, then you decrease the overall costs. When the adult group here studied the impact of their medical home in a pre-post model, they saw really impressive improvements. They saw 47% reduction in ER visits in the post period after they enrolled people in their medical home. They saw a 36% reduction in hospitalizations, not shown here in graphical form, but they also showed significant improvements in mental health outcomes and improvements in quality of health or quality of life scores. And so then that led myself and my colleagues at Nationwide to write up what we were doing at Nationwide Children's as a proposed model of the pediatric IBD medical home. And in this paper, there are multiple different chunks of it, but the first thing we went about doing was attempting to define the roles of all of the different members of the multidisciplinary team. So we have a bunch of different roles here. It's small and probably not legible, but please look up the paper and check it out if you'd like. We talked about who primarily delivers that role at our center, and then knowing that every center has different resources and access to different folks, we also talked about some potential secondary team members that might be able to deliver that care. So this was step one. Who do you want on your team and what jobs can be completed by the multidisciplinary team to really deliver comprehensive care for those patients? We also talked about our processes. So there are a variety of care pathways we have, standardized pathways to help manage Crohn's, to help manage ulcerative colitis. What medicines should we choose based on how severe one's disease is? There are other pathways, which I'm sure you all have in your disease-specific and specialty-specific areas, but how do we consistently manage iron deficiency, intra-abdominal abscess, acute severe colitis, so that we were delivering standardized care? We shared about different data tracking and monitoring systems that are used in this paper. You don't know how well you're doing until you measure it. And so that is something that really helped us in our medical home. And then lastly, we talked about multidisciplinary visits. And this is where I'll spend a little bit of time. We'll return to Alexa and talk about if Alexa was cared for in this medical home, how might have things been better and different for her? So to refresh everyone about Alexa, diagnosed at 13, she had pubertal delay, she had joint pains, she was initially treated with oral medications that she couldn't swallow. Now she's on infusions. Fast forward 5 years, she's getting ready for college, she's dealing with anxiety, body image, dad lost his job, insurance issues. This is regular life, right? This stuff happens. We see patients and may have experienced similar things ourselves. How could we have supported her in this medical home better? So this is what a model could look like. At IBD diagnosis, we start with something called IBD Teaching Day. And I know that actually in the IBD Center here, you have a similar setup, which is very, very cool. So you meet with a IBD nurse coordinator who teaches you all about what is IBD, when to call, what are the symptoms, what are the red flags, how to communicate with us. And you also get an initial touch point with the IBD psychologist who conducts some initial screenings, anxiety, depression, quality of life, intervenes as appropriate. You get an initial dietetic assessment, diagnosing malnutrition or discussing some of those IBD diets that we talked about earlier. You are seen by the social worker who makes sure that you're signed up for all of the insurance plans and supports that are necessary. They get that 504 plan. I'm not sure if it's called a 504 plan in Pennsylvania or not, but the school accommodations plans ready as well. And then some patients are also seen by the research coordinator to get them scooped up into some research right from the beginning. And then over time, there are routine office visits, just as we all have with our patients. But what I feel very, very lucky to have is access to those multidisciplinary team members at almost every visit. And you can pull them in as needed if you need a dietitian or a social worker. I'm also very lucky as an IBD focused person that I have a psychologist that is in most of my clinics with me and we go in together. And so there's not a question of, do you want to see the psychologist, which of course raises all sorts of like, why do you want me to see a psychologist? But we go in together, we're a team, we take care of the mind and the body. And it's really, really effective at decreasing stigma and identifying issues early. And then we are also lucky to have IBD annual visits, also something that is done here, which is very, very cool. And I would say novel across the IBD world, where you get another chance to have a visit with the IBD nurse practitioner, cover an IBD specific transition curriculum, and then be reassessed by all of those team members every single year. So we can identify issues, we can treat them, we can manage them, and really ensure as much as possible that our patients are ready when it's time to transfer to adult care. And then ultimately we can help them find a good adult doctor, get that referral sent, follow up and see if they actually made it, and go from there. So I think that many of the concerns that Alexa and her family had throughout this journey could have been better assessed and noticed and managed if she was in a model such as this. And so that is a lot of stuff. And I think sometimes when people listen to this, they think, oh my, well, we don't have that in asthma. How am I ever going to get there? And so I like to think of what can I do today to improve the outcomes of my patients for whatever disease I care for. You don't have to build a transition program in a multidisciplinary medical home overnight. That's probably not possible. But can you pick one or two small things or get together with your team and think about how you might improve and move things forward? So my first tip would be work with your team. Work with the resources you have, the people you have, including your adult colleagues, and set up a meeting and brainstorm. Where do we want to begin? What one small thing do we want to change to make sure that care is more coordinated and more comprehensive? My second tip would be always consider the biopsychosocial model. We know that physical disease does not live in a vacuum, and if we're not thinking about the mental health and psychosocial well-being of our patients, we're not doing them the justice that they deserve. And then maybe think about developing a transition program. And you don't have to have all the pieces at the beginning. Start small. There's a beautiful website called Got Transition that is free and has a ton of resources. And if you want to start building a transition program, there's a step-by-step guide on how to do it. And if we have time, I can show you some of those slides later. And so before we end here, I would love to ask everyone to make a commitment today. What one thing do you want to maybe do with a patient in clinic that's going to lead toward that comprehensive, longitudinal, psychosocially informed care model? I highlighted some of the blue ones that I've been working on recently, discussing transition early and often, setting mini goals in clinic visits, whether it's putting your pill bottle next to your toothbrush or, actually collecting the stool sample that I ordered 2 years ago. But set mini goals and then write it in your note and follow up on it next time. Share the resources you have, talk to your patients directly, engage them in conversation, engage them in decisions in a developmentally appropriate way. All of these little things I think really make a difference while you're also thinking big about ways to change care models over time. And so I think that is it. I would love to take any questions or comments that folks have. And once again, I really appreciate you all for being here today, the committee for inviting me, and I hope that Dr. Kangos would have found this lecture to be impactful and important. And I feel very, very optimistic about the world of IBD now. I think it's a very different place than it was when he was working through it. And so just thank you, and I'll hand it over to you guys.